treatment of malaria, usually whether severe or complicated, it comprises of specific treatment and supportive treatment. So for uncomplicated malaria, the specific treatment is artemisinin combination therapy. Never use monotherapy for treatment of uncomplicated malaria. One, you will reduce the effectiveness. You will promote drug resistance. So we no longer use single treatments for treatment of uncomplicated malaria. So we normally go for combination therapies and for an artemisinin based. And commonly the drugs we use here are the ACTs. I already mentioned them. They are again listed here. And the first line treatment is artemether-lumefantrine, and the guidelines have not yet changed. So we have a number of brands on the market. We have Lumina, we have Atefan, we have Coatem, you have Lumatem. But all of them are artemether. The generic is artemether and lumefantrine, AL. Then the alternative first line, please note, this is just an alternative. It's like if you're a married woman and you have a concubine. So when your husband is not at your place for some reason, because maybe you're not available, the person who will stand in when you're not there, that one there, that alternative. So here, the first line is artemether-lumefantrine. But this alternative, it just in case the artemether-lumefantrine is not available for some reason, not because it has failed, but it is not available, and what is available is artesunate amodiaquine. The alternative first line is artesunate amodiaquine, Asaka, and the brands are Larimov, Palsimon, Asucam, Ammonite, and Acunate. Then in case the first line fails, person takes a full course that in the appropriate dose according to their age and weight. They don't vomit, they don't share, they store the medicine well, but after completing the dose, they still come back complaining. And when you do microscopy, they are still positive. You now go for the second line because the first line has failed. And the second line recommended right now is dihydroartemisinin piperaquine. But remember, this same drug we are trying to study to use for prophylaxis because it does well. But now the key question we are having, until they introduce other molecules, which they are trying to explore, can we surrender this to prophylaxis? And the answer is that we are holding on. So the brands are duocotexin, pialaxin, Diatep. So there's also another brand that is being used as second line, pyronaridine phosphate artesunate, commonly called Pyramax. Okay, so we're now leaving this to the private sector as we try to understand it more, and then as it gets more available. Some of you could have seen it. So this is the dosing schedule for artemether-lumefantrine, and for children less than 14 kgs, or for that age group, we give them a tab of, and remember that comprises of 20 milligrams of artemether and 120 of lumefantrine. So we give them a tab. In other words, they do 20 milligrams of artemether and 120 milligrams of lumefantrine at when they are still at the facility. Remember, I told you last time. Then you tell them 8 hours after, they repeat. So that's one tablet. And then they do the same. One tablet 12 hourly for the next day, and then one tablet 12 hourly for day 3. And then the same for the ones 15 to 24 kilograms, 3 to 7 years, they do 2 tablets. That means 240 and 240. Also on day 1, they do a directly observed dose, and then 8 hours after, and then 12 hourly for day 2 and day 3. Then 25 to 34, do 3. Then over 35, they do 4. Most of us here do 4. That's about 80 milligrams of artemether and 480 milligrams of lumefantrine. But please note, for where a patient has a Plasmodium vivax, it's important that we add primaquine 0.25 milligrams per kg daily for 14 days. except where, but you should make sure that the patient has no history of glucose phosphate dehydrogenase deficiency. Otherwise, they'll come back to you with hemoglobinuria. Please note that it's very important.
Excuse me, Jen.
Yes.
We didn't hear you for about 1 minute before you reached your conclusion on that. I think your network was not clear. Can you kindly repeat your last explanation?
Oh, I was saying that the above schedule does well for all other forms of Plasmodium species, but where you pick PVVAX, you don't use artemethyl-lumefantrine alone. You add primaquine, and the dosing is 0.25 milligrams per kg daily for 14 days. But first ascertain that this patient has no history suggestive of glucose phosphate dehydrogenase deficiency. Because when you do give this to a patient who has glucose phosphate dehydrogenase deficiency, because you know what glucose phosphate dehydrogenase deficiency does. Normally, these patients that have this glucose phosphate dehydrogenase deficiency is genetically transmitted. Your parents have it, and previously they were saying only male children, but we're also beginning to see it in the females. So what happens is that because by the name that glucose phosphate dehydrogenase, it's an enzyme. This enzyme facilitates a reaction that maintains the membrane of the red blood cells intact. So when one is deficient, and then you give them something like maybe in diety or a drug like primaquine that outcompetes this enzyme, then it gets less and less available. The red blood cell membrane gets unstable, and then the red blood cells rupture easily, and there's hemolysis. And so when you give this patient of D6PD primaquine, they will come back to you with hemoglobinuria. I hope that's clear. Then we also have artesunate-amodiaquine. The dosing is as you see it. Each tablet always has 50 milligrams of artesunate and 153 of amodiaquine. But kindly note that be cautious when you're giving this medicine to people living with HIV, especially if they are on any of those ARVs that suppress the bone marrow, or if by the CBC there are features of granulocytopenia, because this may worsen the picture. It's very, very important that we remember that, and this should be one of the reasons why you may want to do a CBC in your patient, but it's not a very common thing. So the dosing schedule for dihydroartemisinin and piperaquine is like you see it here. Different age groups have different doses, but clearly each tab has 40 milligrams of dihydroartemisinin and 3/10 of piperaquine. And it's usually, depending on the age, you may give a half, you may give 1 tablet, you may give 2, you may give 3, you may give 4, even 5 once daily for 3 days. And then we now come to Pyramax, that is pyronaridine and artesunate. And this is the dosing. This is mainly available in the private sector. I don't know if some of us have seen it. In the supportive treatment, if there's fever, especially members, let's note, ideally, the practice in the facilities is very alarming. Everyone who comes in with a fever, even when they are mildly febrile, they are given paracetamol. But we normally encourage that if someone has a fever, it's until they have a temperature of 38.5 and above that you want to bring on board an antipyretic. But otherwise, before this, give them a chance. Do other measures of temperature control. Give them plenty of cool fluids. Expose them, tepid sponge, and then before you can do paracetamol. But in case you feel the temperature is very, very high, you may want to do paracetamol, 10 milligrams per kg every 6 hours. and you can even do 4 hours in some cases. And then you would want not to exceed 3 days because you don't want to mask symptoms. Or you give them ibuprofen 5 milligrams per kg. This last bullet is speaking to what I just said. You don't want to do antipyretics for more than 3 days, because then what that means is that you may mask the symptoms and you may not know if a patient is not improving. So what are some of the common errors we do in the management of malaria? Presumptive treatment. When you do presumptive treatment, you're likely to miss the real diagnosis, worst antimalarials, and then you're likely to contribute to the development of antimalarial resistance. Delay in starting antimalarial therapy. Remember, we're dealing with P. falciparum. Patient is likely to progress to severe disease. Partial treatment or incorrect doses, you're creating drug pressures and you're contributing to the development of resistance to antimalarial medicines. Monotherapy is no longer promoted in this era. Because as we speak, as one way of responding to the increasing levels of resistance, we are actually going triple therapy. You're going to soon hear that we are adopting drugs that have more than 2. They have 3 drugs. The ones that are available have actually, the ones they are proposing are going to be containing 3 drugs. Delay or failure to refer a patient who needs referral. This is common in the private sector. Because someone has not paid, you still want money from them. Even when they can still move to the facility and be better managed and better diagnosed, you keep them until they become severe malaria and die on the way. Inappropriate route of transmission. Patient has severe malaria, you're giving them oral treatment. The other practice is because you want to please the patient, you're giving them injectable treatment, even when they would have benefited from oral treatment. Failure to recognize severe malaria. Members, this is where I'm emphasizing. Let's learn the danger signs and be able to align them to complications so that we can identify complications. By you identifying the complication, then you're easily making the diagnosis of severe malaria. Failure to recognize and treat other conditions. Patient does not recover, they keep coming to you, you're doing a BS, sending them to the lab repeatedly because you didn't do a complete assessment to identify other causes of other comorbidities that may be keeping this patient in your queue. So this is important that we are able to identify other comorbidities. So now this brings us to severe malaria. These 6 things, please remember them. They are the ones that are going to contribute to the other goal up there, reducing morbidity by 75%. All your facilities, even if it's your private clinic, have a functional triage point. Whenever you've committed or decided that you'll manage severe malaria, have a functional triage point, because this is where you're going to timely identify danger signs and be able to stabilize the patient in the resuscitation. So here we expect that this point is at the point where patients get the first time they enter facility. It should be equipped and should have a staff who knows how to triage. So by so doing, you're going to be able to pick danger signs and be able to identify complications. Immediately you do this, respond by doing resuscitation. So there should be a simple resuscitation room with a well-equipped tray and staff who knows how to do resuscitation. One time I went to a health center and someone was saying they were resuscitating a patient. They were doing cardiac massage, and they were busy pressing the stomach, and the patient eventually vomited and aspirated, and the situation got worse. These things happen. Someone has seen someone do it, and they think they just put their hands anywhere and they do the cardiac massage, but that is not what they never learned. It starts with understanding the objective of what you're doing, so that you then understand what you're doing, and then you're able to do it right. So resuscitation room, well-equipped, staffed, and you'll be able to respond to an emergency in form of a complication. Then specific treatment It aims at clearing and reducing the parasite load. Then after you've stabilized your patient, the next thing is monitoring and nursing care. Because some patients tend to revert. So when you monitor, you're able to know if your patient is getting better or they are developing new symptoms, and you're responding on time so that you facilitate the progressive improvement of your patient. But how about when you can't manage? Do an appropriate referral. But after all is done and patient is well, kindly, all severe malaria patients should be followed up. Because there is evidence, actually the Dr. Idros study with Dr. Dabanja and Dr. Opoka, they documented that a number of patients who we discharge actually die in the community. They never come back to us, especially the children. Because they go back into this house where they picked malaria and they left after infecting other people, they reinfect them, and then the malaria is now coming into an already weak body, and now this time around they don't even come back to, they die in the community. So follow up is very, very important. You're going to see how long we follow up. So what are some of these danger signs, emergency signs? Obstructed airway, as is seen by the noisy breathing. Central cyanosis, purple coloring of the tongue. Respiratory distress, a rapid weak pulse. Cold and blue hands, those are cold extremities. Slow capillary refill of more than 3 seconds. Lethargy or unconsciousness. Sunken eyes, very slow skin pinch. Convulsions at the time of examination. Severe anemia, as is seen by the severe pallor of the palms and mucous membrane. These are danger signs. Obstructed airway. If the airway is obstructed, do suction. Position the patient. Some people, when the airway is obstructed, they just put on oxygen. Now, where is the oxygen going to pass when the airway is obstructed? The moment that you pick noisy breathing, most likely there's obstructed airway. Try to suction the patient and position them well. And then if a patient has cold extremities, this is a sign that they have shock. Aggressively hydrate them. There are a number of things that we're going to see. But then the priority signs include convulsions or fits in the last 2 days. It's very different from when you have active convulsions. And then notably not able to drink or breastfeeding, vomiting everything, altered levels of consciousness, maybe someone is in prostration, respiratory distress, dehydration, severe malnutrition, a sick young infant, especially if they're less than 2 months. Then if someone has been referred, temperature above 39.5, a trauma patient, a poisoned patient, someone who is restless, even someone who is very quiet, burns, edema of both feet. These are priority signs. So after I've dealt with the emergency, see these ones first. Remember, as we work, let's be able to understand the difference between history of convulsions. That one makes a patient priority. And if a patient is convulsing, that one makes a patient an emergency. Then you also not every convulsion points to a severe disease. If someone reports one convulsion in 24 hours and they've walked in, they're only giving you history. Or they convulse there, but convulse for less than 30 minutes, and then immediately they gain consciousness, and they are convulsing because they are hot and a child of less than 6 years. Most likely that's a febrile convulsion. Try to control the temperature, because there's a WHO definition of febrile convulsions. I would beg that we go and read it up. There's a clear age category tagged to it. Normally, that convulsion does not last long. Patient gains consciousness immediately, and they usually get one like in 24 hours, and it never recurs unless they get another fever episode. We need to understand the difference. But if a convulsion is happening because of cerebral malaria, hypoglycemia, or a meningitis, you can get like 6 in a row, and then they last longer, and someone takes long to gain consciousness. You know, you need to differentiate these things, because at times you may have a long queue, and then you end up having every child who's coming in with febrile convulsion as an emergency, and you're admitting and filling your ward, and they're all into your high dependence area. Well, you need to be able to ration and make decisions rationally, because at times you may confuse a few things. So what are some of the complications we're having, and how are they described? When you're speaking severe anemia as a complication, I told you the danger sign here you will pick is severe pallor. So severe anemia here, you have a patient who presents with severe pallor, a low hemoglobin of less than 5 grams per deciliter, or a low hematocrit count, or a low hematocrit count of 15% with a parastemia. This is severe malaria with severe anemia. The complication here is severe anemia, and this is what makes it severe malaria. But however, note, this HB cutoff is for someone who does not have the following. In pregnant women, we shall say less than 8 grams per deciliter. We know the reasons why. In someone who has a heavy parastemia, the 5 grams per deciliter may deceive you, because hemolysis is enormous. So anything less than 7, you may want to act. Someone who has cardiac disease, non-cardiac disease, or non-chronic kidney disease, you may not want them to come to this level. You may want to act at a higher level. Someone who has sickle cell anemia or septicemia, this may not apply. So please note those differences. Hypoglycemia, you have this patient who has a low blood sugar of less than 60 milligrams per deciliter, or less than 3.0 millimoles per liter. The patient has mental confusion or extreme weakness, or they are sweating, or they have convulsions, or they are in coma, or the patient's condition that may be deteriorating very, very fast despite the use of antimalarials. And they have a positive slide. Most likely we are dealing here with an hypoglycemia, and they've told you the danger signs to look out for. Then repeated convulsions, a history of 2 or more convulsions in 24 hours. You're seeing this here, 2 or more convulsions in 24 hours, because they want you to differentiate between convulsions due to some of these morbidities like cerebral malaria, meningitis, and febrile convulsions. Take note of the subtle convulsions such as nystagmus, fixed conjugate gaze, because this is a common one. You're not seeing anyone convulsing, but they are simply having nystagmus, or they have a fixed conjugate gaze, or they are frothing, and then you think, and then you know you're missing out on the convulsion, but it's happening. So repeated convulsions. Circulatory collapse, as is picked by the thin rapid pulse and the low BP according to age. Then fluid, and then the positive slide. Then fluid and electrolyte imbalance. Patient often presents with hypovolemia or features of hypovolemia. Clinical signs of dehydration, we know them. Slow skin pinch, coated tongue, and name them. So baby's crying, they're not tears coming through. The mucous membranes are dry. Acidosis is a major electrolyte disturbance. It presents with low plasma bicarbonate of less than 15 millimoles. And then hyperventilation and deep breathing. So these are some of the things you may pick, and then eventually you know that either I am having fluid and electrolyte abnormalities, and then you have a positive BS, and you have to act fast. Then hemoglobinuria or black water fever. This is becoming very common. We are dealing with this. It's a very big problem we first reported it in Mbale. Then we picked it in Teso region. It's now very common in Bukedi, Busoga, and everywhere in the country we're beginning to get this as a complication. And we're trying to understand why. The number of questions being asked, is it entirely G6PD? Could it be happening in places where we're having high burden of sickle cell? Is it the drug we are using that is causing us this? Could it be the diet? Is it the loss of immunity? A number of things are being asked, and we shall be sharing a report soon as to why this is becoming a very common complication. So the patient presents with hemoglobin or myoglobin or a protein in urine that is characterized by them passing dark-colored urine, normally described as tea-colored or Coca-Cola-like, and then positive heuristic test for blood, but no red blood cells on microscopy. Please note that, because you're trying to differentiate this and hematuria. This is due to the hemolyzed red blood cells that are broken down by the parasites. But it can also be to the massive intravascular hemolysis that could be induced by drugs like quinine in patients that have glucose phosphate dehydrogenase deficiency. Then the renal failure is becoming a very common complication in form of acute kidney injury. And the patient here will present with failure to pass urine, or they are passing for several hours, or their urinary output is less than 0.3 mL per kg per hour for children, or less than 17 mL per hour for adults, despite adequate correction of dehydration and hypotension. Normally, when you do the plasma creatinine or blood urea, you realize that they will be raised. And please, you should be knowledgeable of the normal levels of creatinine or blood urea for you to be able to pick this. Then the other complication is, and in all this, you have either positive RDT or microscopy. Then there's spontaneous bleeding. Spontaneous bleeding, you have someone has bleeding tendencies such they could be bleeding from the gums, they could be bleeding from the nostrils or under the skin or subconjunctival, and it is very rare, but it occurs in the non-immune, such as the travelers. In I think 2008. I got this Canadian visitor who had gone to visit some chival, I think, to see gorillas or something. So while there, I felt unwell, and where I first went, they tested for malaria. They didn't see anything, so they came to the clinic where I was, but by then they had bleeding under the gum and under the skin. So when we sent a sample to the lab, there were scanty parasites, and then the platelets were only, I think, 9. But even before the results could come back to us, this gentleman was convulsing, and because I was in a clinic, we couldn't keep them there, so we sent them to Mulago. But I think immediately they reached Mulago because they were having repeated convulsions because of intracranial bleeding. The young man died. So spontaneous bleeding in malaria is not a very common thing, but it happens in the non-immune. And just like we didn't before have lots of acute kidney injury, but we are beginning to get increasing numbers of acute kidney injury and even hemoglobinuria, this can also change trend. And so we need to learn that it happens and be able to identify and manage it. Then respiratory distress. You may have deep breathing, astotic breathing, or astotic or sweet smell breath. Remember, someone said last time that what if I get this woman? She's not diabetic, but she has malaria parasites, and then I pick ketones in urine. What would you think of? Especially if they have these symptoms, suspect that they could be having acidosis, because it's a common complication of malaria. Then pulmonary edema, features of respiratory distress, nasal flaring. They have a positive RDT. You do a chest X-ray and there's a glass eye appearance. You auscultate, there are crepitations, suspect pulmonary edema. And then of course also acidosis comes again. And then cerebral malaria, more than 2 convulsions in 24 hours. Glasgow Coma scale of less than 10, a positive RDT, and normal CSF. Please note, normal CSF is emphasized. So here you're dealing with cerebral malaria. So having identified all those complications, how do you manage? How do you manage? So we shall start with number 1 complication. You've made a diagnosis. You've seen how we identify. Hemoglobinuria, black water fever patients. How do you manage? Key thing, rehydrate the patient to avoid the accumulation of hemoglobin in the renal tubules, because this may lead to acute renal failure. Make sure you withdraw all drugs that may facilitate intravascular hemolysis. If the HB is lower than 5 grams per deciliter, or even less than 7 grams per deciliter, especially in the situation of heavy parastemia, transfuse this patient. When you're discharging this patient, make sure they keep coming back for you to follow up. Then the patients that are having spontaneous bleeding, in most cases, it will be because of the low platelet count. Preferably transfuse this patient with fresh whole blood. Fresh whole blood, why? Because we all know the lifespan of platelets. If you use old blood, you'll be transfusing yourself. You're not helping the patient, you're helping your ego, you're helping yourself. But if you can access platelets, give this patient platelets. So for acidosis, we already defined it. Give a bolus of IV fluid like normal saline, and if IV access cannot be achieved, use a nasogastric tube. You can give oxygen. You can give sodium bicarbonate if a serum lactate is high, and then you make sure you exclude features of hypovolemia. Then fluid and electrolyte imbalance, we normally prefer that you rehydrate with normal saline or Ringer's lactate. We shall see how to manage the fluids down there. Then acute kidney injury or renal failure, make sure you've excluded pre-renal causes like shock, hypovolemia, severe dehydration. If they are there, hydrate aggressively. And then check the fluid balance. What is the input? What is the output? Urinary sodium. If the urinary output is inadequate despite sufficient fluid replacement, you will want to give a diuretic or dopamine. If this fails, refer for dialysis. This is very, very important. And then for respiratory distress, make sure you've excluded other causes of respiratory distress. If you think it's acidosis, you rehydrate the patient with Ringer's lactate. If there is cyanosis and oxygen concentration is less than 90, put the patient on oxygen. Get to understand if this patient is into moderate hypoxemia or severe hypoxemia, and decide the mode of delivery. Members, please, let's avoid the practice of saying give oxygen, because SpO2 is less than 90, and then you simply write give oxygen. Understand the age of the patient. Understand the level of hypoxemia. Pick on the correct mode of delivery and write it as you're writing. Give this amount of oxygen, say maybe 3 liters of oxygen by nasal prong. And then, or maybe by rebreather mask, you're giving, say, maybe 8 liters of oxygen. But what happens on the ward? You simply say, give oxygen. And our dear nurses also give oxygen. Whether they're giving 10 liters of oxygen, about 10 liters per minute by nasal prong, that is up to them. And so the results are not what we usually want. So that's how we manage the respiratory distress. Then how do we manage cerebral malaria? Make sure the patient is positioned well. Make sure the patient has a nasogastric tube because they have to feed. Make sure that the patient is catheterized. If you're not going to catheterize the patient, make sure that you change the beddings regularly. Make sure the patient airway is clear. Make sure the patient is breathing. Assess the circulatory, the cardiovascular system. Make sure the patient is not having any deformities, or they are not convulsing. And so normally you'll want, if they are convulsing, you'll want to give diazepam, and we usually prefer that we use rectal diazepam at 0.5 milligrams per kg. And then if convulsions have not stopped after 10 minutes, you may want to repeat. Don't give more than 3 doses of diazepam in 24 hours. I think we all know this. Normally, when you fail with the first doses, you may want to change phenobarbital of phenytoin, and the doses are in there. But it's important that you understand the cause of the convulsions if the convulsion is on, manage accordingly. Remember to start specific treatment. And then for repeated convulsions, the treatment is already up there. Then for severe anemia, normally for severe anemia, you want to do group and cross match, and then we know how we give. Then you want to transfuse 20 mils of whole blood or 10 to 15 mils of packed cells. But normally when you're giving whole blood, you want to give Lasix. And then at times you may even want to put your patient on oxygen. Because remember, when one is anemic, the oxygen carrying capacity is compromised, and you risk getting hypoxemia and worsening organ function. And then circulatory collapse or shock. Make sure you have completely ruled out septicemia. Remember last time I told you that there's this so-called algid malaria. Algid malaria, you have a malaria patient, they have features of shock, and it has been found out that in most cases the cause of this shock could be a gram-negative septicemia. And so doing a blood culture is very, very important, because you could give your IV fluids and your specific treatment, and your patient is not improving because you've not identified the septicemia and covered them with broad-spectrum antibiotics. Then, of course, then you go ahead to correct the hemodynamic changes by giving IV fluids. Normally, the dosing, you give a bolus of 20 mils per kg slowly over 15 minutes, then reassess. You can give up to 3 doses, and there was that time when they used to advise that when you've given 3 doses and a patient is not better, at times you may want to transfuse. But in most cases, patients improve up after this. Then for pulmonary edema, I could have forgotten the slide on hypoglycemia. I hope not. Not seen hypoglycemia anywhere. I hope I didn't forget the slide on hypoglycemia. That will be bad. Pulmonary edema, but I'll speak through it. Pulmonary edema here. You remember we assessed and made a diagnosis, and clearly you'll want to prop up the patient in bed at an angle of 45 degrees. You'll want to minimize IV fluids as much as possible, and then you'll want to give IV Lasix 1 to 2 milligrams per kg. And for hypoglycemia, normally you'll want, if it's an adult, you'll want to give 25% dextrose, 1 to 2 mils. And you want to, if a patient is not able to drink after that, you'll want to pass a nasogastric tube and calculate the feeds they're supposed to get every 2 hours. Later when they are able to feed, they will be encouraged to feed. And then for children, we normally will want to use 10% dextrose and usually give 5 mils per kg. And in most cases, you don't want to keep repeating the dextrose, and you want to pass a nasogastric tube and give this patient a chance to feed via the nasogastric tube until they are able to feed on their own. I think that is it about supportive treatment, and this takes me to the specific treatment. Remember, I told you that the preferred treatment of choice is injectable artesunate by IV or IM. The available strength of artesunate is 60 milligrams vial. And in here, you have a 60 milligram vial of artesunate powder in form of artesunate acid. And then you have an ampule of 1 mil in that 60 milligram pack of sodium bicarb for reconstitution. And then you have 5 mils of sodium chloride for dilution. Like I said, it's important to weigh the patient, determine the vials you need, and then you now reconstitute. Clearly, how will you know that you've successfully reconstituted? The mixture of the powder and the sodium bicarb gets clear. If it's still cloudy, it means the reconstitution has not successfully taken place. I told you the other time that the powder is an artesunate acid. Artesunate in an acidic mode is unstable. and it will not be available to attach to the ring of the parasite in order to destroy it and clear the parastemia. And so is the case when it is in alkaline mode. So it's in mode. So it has to be neutral. And how you know that you've neutralized it is by it getting clear. The other thing, as you're shaking, you shouldn't shake vigorously, because when you cause a rise in temperature in that environment, it still gets destabilized. And these are some of the things that we give issues with the response to treatment. So reconstitution, this stage is very, very important. Then dilution will depend. This reconstitution does not matter if you're going to give IV or IM, because if you're going to give IV on the dilution stage, then now you're going to decide, am I going to put on 5 mils, or am I going to put 2 mils? If you're going to do IM, you want to do 2 mils. If you're going to do IV, you want to add 5 mils of the sodium bicarb. And then after that, now you want to calculate the dose in mils. This is what the person who is going to give, this is what matters to that person, because she wants to know how many mils to give. And now here you'll use the concentration you attain when you dilute. When you dilute for IM, normally the concentration of your mixture that you get will be 20 milligrams per mil. So that is why you divide by 20. Then here you get 10. That's why you divide by 10 for the IV. So then the key question here is that, do you remember the weight of your patient? If they are more than 25, then you will want to multiply by 2.4. If they are less, then you want to multiply by 3.0. So and then you get the mils. But like I said, when you get the mils, they may be in decimal point, like you get 1.4. When you get 1.4, you round off upwards to 2. Same as when you get 1.8. So even if you got 1.2, you round off upwards. Why? When you give less dose of artesunate, you're likely to get to interfere with your parasite clearance. And yet you need very many milligrams of artesunate for you to cause toxicity. That's why it's easier for us to round off upwards, because then you're confident you're not easily going to cause toxicity. But then if you round off downwards and reduce the dose significantly, the parasite clearance may be interfered with. So you always prefer to give your dose in mils, in whole numbers, because it's easier to draw. Then now you decide if you're going to give IV, the cannula will be there. But if it's IM, you're going to give it in the thigh. You divide your thigh into 4. You draw a perpendicular line that divides your anterior thigh into left and right. Then you draw a vertical line that further divides your thigh into 4 quadrants. And you want to use the upper outer quadrant, because then you're sure there the sciatic nerve is safe. Someone asked a question last time, that is there maximum dose? Previously there was, but I think the new guidelines are emphasizing that you give any dose that you've decided, depending on the weight of the patient, per milligrams per kilogram body weight. And now, so having done that, how about in a situation where where your level cannot manage and the patient has to be referred? Starting point, what is so threatening in this patient? Is it the temperature? Control the temperature by exposing this patient. I don't like using this word undressing, I'm sorry, it's in my slides. Expose the patient by taking off clothes, tepid sponge, and where necessary, give them paracetamol. If there are convulsions, control the convulsions by giving rectodiazepam. If if a patient is drowsy or lethargic, give dextrose. If you can't give because you can't access a line, patient is conscious, the solution, and if it's time to So when dextrose is not available, prepare a sugar solution, get sugar and water, get 20 grams of sugar, which is equivalent to 4 leveled teaspoons, and put in 200 mils of clean water, clean, safe drinking water. And you encourage the patient to take this mixture. That is if you don't have dextrose. So you get 20 grams, and here get 4 leveled teaspoons and put in 20 mils of clean water. You can give 50 mils of this solution either orally or by nasogastric tube. However, remember to confirm the diagnosis and provide results. If less than 6 years or less than 5 years, okay, 5 years. I'm sorry, I maintained 6. I think previous guidelines were saying 6. I'll correct this before I reshare because I'd already shared. Give 10 milligrams per kg of rectal artesunate suppository. If the suppository is expelled within 30 minutes of insertion, make sure you put a second one. If young children, make sure I squeeze the buttocks for about 10 minutes to make sure that the rectal artesunate is retained. And if more than 3 suppositories are needed, first put the 3, then wait about 10 minutes and put another. In case suppositories are not available and what you have is IM artesunate or quinine, you can give IM, either artesunate or artemether or quinine as your pre-referral treatment. Remember also in the older age group, we are giving IM artesunate or IM quinine or IM artemether. Give patients oral fluids if they are dehydrated. Talk to them, explain to them what, for example, what you have, the entry point is the danger sign because it's what they see and it's what you see. Tell them what the implications of that and tell them why you can't keep them in that facility and the reason they should move quickly to the next facility, and write a proper referral. What were the complaints of the patient's full names, the time they came in, what were they complaining of, what pre-referral treatment have you done, the lab results if you have them, and then reason for referral, and then refer them to the next level. That is what we call appropriate patient referral. And then it's important that as you give the above treatments, resuscitation, stabilization treatment, and then specific treatment, and patient gets stable, we encourage that on the ward should be sectioned in such a way that you have a high dependence area, you have a general area, and then you have a convalescing patient area. In the high dependence is where you're putting this patient who needs close monitoring, and you're going to be monitoring them regularly. As they get better, they move to the general bit, and as they are about to go home, they go to the extreme end of the convalescing area, because there you're educating them, you're preparing them for when to come back, the follow-up, and then before they go home. So as you're monitoring, what are the parameters? Level of parastemia, if they are pregnant, PV bleeding, fetal movements, pressure sores, color of urine, convulsions, breathing, urinary output, and every finding you pick, like for example, for level of parastemia, if positive BS, the BS is still positive, same level of parastemia as before initiation of treatment after 3 doses of treatment. Revisit the doses of treatment, make sure you're giving the correct dose, make sure the mixing is okay, and then if everything is okay, but a patient is not improving, you'll want to change to some other treatment that is not injectable artesunate, and this in most cases we go for quinine. But if there were issues with the dosing, you adjust the dose. If there were issues with the reconstitution, you correct the reconstitution, and then you give it another 24 hours. But if you come back despite all that and the patient is not better, you want to change to some other treatment. Then for PV bleeding, of course, you now want to do an ultrasound scan And if it's depending on what is giving you the bleeding, you act accordingly. Pressure sores, of course, you need to catheterize the patient and turn the patient in bed regularly. Then color of urine, if someone is passing tea-colored urine, and hemoglobin is above 8, you want to monitor HB. But if less, you may want to if less, you may want to group and cross match and consider transfusion. Then if it's convulsions, make sure you don't miss the subtle convulsions, and you take the random blood sugar, and then in case kindly note there was a mismatch in the reading. What is correct is this one. The random blood sugar in millimoles is 3.3. Sorry for that error. And then in grams, I think is okay. I made an error up there, sorry. So you control the convulsions with diazepam, correct the sugar levels, and then you make sure you rule out other causes of convulsions. You'll want to do culture and sensitivity, CSF analysis, and manage accordingly. I already spoke to the action you take if you think it's hypoglycemia. I hope all of us know how to prepare the 25% and the 10% dextrose, because it's very important. Then follow-up. Follow-up is very important, but before I leave here, please note that after I've completed the dose of IV artesunate, like for example, you've done the 0 hour, 12 hours and 24 hours, 8 hours after, the new guidelines are indicating that you don't continue with that methylomephantrine, as has been the practice for all severe malaria patients. You continue with a full course of dihydroartemisinin, piperaquine, as I shared above. And in your follow-up plan, when the patient comes on day 28, you give them another dose of dihydroartemisinin, piperaquine. But where we are not so sure of the follow-up, actually what we are encouraging right now is that you give the patient their dose for day 28 to go with at home, and remind them to take it after 28 days. But the ideal should be that they come back for follow-up. So whenever a patient comes back for follow-up, a neurological examination should be done. It's important that we assess the patient's functional capacity. How is the vision and hearing? Do a thorough exam and check for anemia, jaundice, and the general nutritional status. Health educate on malaria prevention, because remember, we're also emphasizing that all these severe malaria patients should be discharged with a mosquito net. Where you need specialists review or physiotherapists or ophthalmologists, send them. The follow-up plan should be day 7, day 14, and day 28, and thereafter you do it monthly until until 6 months. There you'll be sure that patient is better and they've not gotten any new episode. Commonly at this visit, you'd really want to do a PCV on day 7 or day 14. Why? Because our current treatment is artesunate, and most of our patients usually come in with heavy parastemia, and there's what we call the post-artesunate hemolytic anemia that could be silently killing patients. So this is one other reason we need to follow up patients, because of the way artesunate works. Artesunate goes and attaches itself to the ring of the parasite, and so what happens is that it's hooked out of the red blood cell, and there will be dimpling. So the red blood cell will lose its biconcave donut nature-like appearance, and so now the body will look at it, will regard it as a foreign body, and then it will facilitate the mechanism of breaking it down, and there will be hemolysis, and that is what gives you the post-artesuneteous hemolytic anemia, and that is one of the things we look out for here when the patient comes back. So then there are two things we should discuss as we wind up. How do you deal with a patient who you suspect to be failing on treatment? You'll still do your history taking, systemic exam, and then a laboratory test, and then depending on the results, you'll make a decision on what to do. So in your history taking, you'll assess the patient for danger signs, review all systems, including history of previous treatment for current illness and any chronic conditions. Then you're going to examine just majorly to rule out other comorbidities. Here, up here, you're doing all this history to make sure a patient did treatment well, they never exchanged it, they kept it well. And then here, you're trying to be sure there are no other comorbidities. So assess duration since last malaria treatment was taken. Remember, we defined treatment failure up there. So you ask yourself, if this patient in the history completed treatment, they didn't share, they didn't vomit, how long ago did they complete treatment? If they completed treatment less than 28 days ago, then, and in your lab test, remember here, we said you don't do RDT. Here you're doing microscopy. So in your lab test, you're still getting malaria parasites. Or you have a situation where the patient completed treatment more than 28 days ago, but still you're getting parasites. So here the patient is positive or they are negative. So if it is in a situation where it's less than 28 days and they are less than 28 days and they are positive and they don't have danger signs, then you're still dealing with uncomplicated malaria. That is if there are no danger signs. But if they are negative, then based on what you found here in your physical exam and probably also in the history, and they are negative, probably it could be some other illness. But if it's more than 28 days, then still it's malaria if it's positive. And so, and then also when it's negative, then it could be other comorbidities. So if it is less than 28 days, then it's a treatment failure. If it's more than 28 days, it is either reinfection or a recrudescence, as we saw up there. So where you don't have danger signs, will treat as uncomplicated malaria. So since it's treatment failure, you're going to go into the second line treatment, which we saw up there as dihydroartemisinin, piperaquine, or quinine. However, if there are danger signs, you will want to first do the recommended treatment for severe malaria, which is IV artesunate. And then you assess the patient and then continue with dihydroartemisinin, piperaquine. However, if it's negative and there are no danger signs, you will treat other causes. And if there are danger signs, you treat a severe disease with IV antibiotics. So, but however, if it's recrudescence or reinfection, you will want to do the first line usual treatment. Or if it's severe disease, you'll still do IV artesunate and then continue with but remember, we have said for all severe malaria, we'll continue with dihydroartemisinin, piperaquine, which I will correct there. So then, how about a patient who comes with a fever? The RDT is negative, microscopy is negative. Remember, there are other causes of fever. You assess this patient head to toe. In the head, think there's meningitis, there's conjunctivitis, there's otitis media, there's tonsillitis, there's pharyngitis, there's calm down, there's laryngotracheal bronchitis, there's laryngitis, there's bronchitis, there's pneumonia, there's hepatitis, there's enteric fever. Members, enteric fever. We need to, I think we need to understand that enteric fever is becoming another problem. Everyone somehow, somewhere suffered from enteric fever. Someone gives you that diagnosis somehow, but I don't want to go there. So there's enteric fever, there's pelvic inflammatory disease, there's pyelonephritis, there's cystitis, there's myositis, there's a number of things. There are these skin things, measles, there's herpes zoster, there's a drug reaction. All those things will give you fever. That's why you have to look at the patient from head to toe and make sure you've explored everything. So assess the patient for danger signs, just to be very sure they are not an emergency. Then review all systems And then after that, you now examine the patient. Then do lab. Here you're going to do microscopy and other investigations. If the result is positive, manage as uncomplicated or severe malaria. If it's negative, then manage those things. We said respiratory tract infections, pelvic inflammatory disease, urinary tract infection, ear, nose, throat infections, GIT conditions. If there is no evidence of disease, you'll want to still cover the broad spectrum antibiotic. If a patient has danger signs and you fear that having missed something, they may lose their life. And if you've taken history and you think there's something suggestive of malaria, that's why we leave that window of 2% for one to think through. But normally here, if there are no danger signs, kindly refer to a high level for someone more specialized to do an assessment and decide what they want to do with the patient. So here with malaria, I've seen we do first line, then severe, we do injectable treatment. Then here for other diseases, go to the UCG and get guidance on how to manage whatever you would have identified. So this brings me to the end. Thank you so much. Questions are welcome. Let's chase malaria out of Uganda, chase malaria out of Busoga region.
Yes,
Let the next malaria indicator survey find us at less than 5%. Good luck. Thank you so much.